safe havens from the Tigray conflict. Now the sound of hammering and digging rings out as people build temporary huts, while elsewhere, children take lessons in makeshift classrooms. Young people kick a football around in the dust, while others line up to refill containers of water. Now, according to the UN Refugee Agency, more than 44,000 refugees have crossed into Sudan since fighting broke out in Ethiopia's northern Tigray region on November 4th. The rapidly growing Umrakuba refugee camp once housed refugees who fled Ethiopia's 1983 to 85 famine that killed more than 1 million people. It was closed 20 years ago but reopened for a second time earlier this month. Elsewhere, Boko Haram fighters killed at least 43 farm workers and injured 6 in rice fields near the northeastern Nigerian city of Maiduguri on Saturday. And Nigerian President Muhammadu Buhari has condemned that attack, saying the entire country has been wounded by these senseless killings.
We shall ensure recruitment of more civilians, yet more hunters, so that our people will take the fight to all the nook and crannies of this area, while we can still appeal to the Nigerian military as well as the Nigerian Air Force to strengthen their support with a view to defeating them.
At the Matai school near Tripoli, teachers and parents are using the limited means at hand to repair buildings devastated by a year-long battle for the Libyan capital. Some of the walls have been repainted, furniture has been installed and aging computer screens dusted off. But the roofs and other walls, pock-marked by gunfire and mortar blasts, remain grim reminders of the recent fighting. When Eastern Libya military chief Khalifa Haftar launched an offensive in April of 2019 to seize the capital from the UN-recognized Government of National Accord GNA, Ain Zara found itself on the front line. Now the fighting degenerated into a long battle of attrition on the outskirts of Tripoli and lasted until June this year, when pro-GNA forces ended the stalemate by pushing Haftar's forces back eastwards. Now, at least 14 former miners in Zimbabwe have been trapped underground after a shaft in a disused gold mine collapsed. The incident occurred late Wednesday last week in the town of Bindura, north of the capital, Harare. 6 miners have since been pulled from the rubble and taken to hospital. And according to mining officials, those who were rescued there were about 40 people in the mine shaft at the time of the incident. Hence, rescue efforts are still ongoing. Mining is a major source of foreign currency for Zimbabwe, where gold alone accounts for 60% of exports. The landlocked southern African country is home to vast gold and mineral reserves, including diamonds and platinum. Now, away from that, a new analysis by the World Health Organization finds that Africa is far from ready for what will be the continent's largest ever immunization drive against COVID-19. According to WHO, Africa's coordinator for the Immunization and Vaccines Development Program, the region has an average score of 33% readiness for COVID-19 vaccine rollout, which is well below the desired benchmark of 80%.
And experience have shown that when we have an average or weighted score around 80% or above, clearly it shows that the country can safely deploy a vaccine or conduct a vaccination campaign to reach the maximum of the impact. So we are far from getting there. So far, the weighted average is around 33%, but we need absolutely to work and support country to make sure that the countries can bring up all of their different pillars of vaccine introduction to a level where if a vaccine becomes available soon, a country can safely deploy the vaccine to reach the maximum impact.
Many countries are keen and determined to get the vaccine on time. We do know that African countries are concerned and hoping that pre-ordering of millions of doses of vaccine by wealthy countries will not disadvantage their accessing supplies. I think this is very much the issue of today that's being discussed all over, especially in the region.
My feeling is that although we have these vaccines that are effective, appear to be effective, and as Dr. Mweta has mentioned, the plans to roll them out, this should not stop the research and development of newer vaccines.
Now to our focus of our conversation this morning. Millions have died needlessly from AIDS-related causes due to lack of access to existing therapies, according to the UN AIDS chief, who has called for a fairer approach to tackling the coronavirus pandemic.
And what we are saying as UN AIDS is that let's learn from the bad experience of AIDS. When medicines were found, but it took 10 years before people in our region, Africa, could benefit before prices came down for them to save their lives. We're saying this time, let us have a common pool. It can't be that those who are wealthy come and book out supplies and everybody else dies waiting for. Even those who are not at risk but happen to be rich are vaccinated. That's unjust. If we can align the world behind a new model for developing and distributing health technologies, definitely this will impact the HIV solutions for HIV as well as for others. Currently, we have many diseases in poor countries whose solutions are actually there or close, but because they don't make up a market that will make a profit for some private company, the solution isn't available for them. To me, that is a violation of human rights.
Definitely concerns that are coming out from stakeholders in the HIV and AIDS management and treatment, of course, and prevention of the same on this fast day of December. Remember, it's a World AIDS Day, the day that we take time to actually understand what or where we are at in as far as this epidemic is concerned, and of course celebrate those who are living positively with the same, and remember those who have succumbed to AIDS-related diseases. And to help us understand what the status of Kenya is, in studio with me, Dr. Charlotte Paherogo, who is a pediatric adolescent technical advisor at the National AIDS and STIs Control Program, that is NASCOP. We are also joined by Elizabeth Mweni, who is the County TB Leprosy Coordinator at the Nairobi Metropolitan Area. Thank you for your time. Virtually, we have Dr. Cornelia Ochola, who is a HIV technical lead at the Center for Health Solutions. Thank you for joining us. Also joining us from the comfort of her home is Emily Muga, who is the head of Global Fund Program at the Kenya Red Cross. And also joining us virtually is Judy Ateno, who is a community ART treatment supporter from Siaya County. Thank you all for joining us. And it's interesting that we have female representation this morning. I think this is where we actually challenge more men to be part of this conversation. But even as we talk about the status of Kenya, I'll start off with you, Charlotte. Commercial HIV and COVID-19 hashtag Tuwajibike is actually the national theme this year for this World AIDS Day. So why does the fight to end COVID-19 critical in the fight against HIV?
Okay. Thank you so much, Gladys, for having me this morning. So one of the things that came out really at the beginning of the pandemic was that any person whose immune system was compromised in one way or another was actually found to be more at risk to suffer from COVID-19 or the morbidities. So then it became very critical for us as a country. I think as Kenya, we have the 4th largest epidemic in the world. So it became very critical for us to really make sure that about 1.6 million people living with HIV in the country are actually safe. So for us, making sure that they stay healthy and stay alive means then making sure that they stay free from COVID-19. So then the joint discussion to sort of make the two actually go hand in hand.
Okay, yeah. So there is emphasis that HIV and STI essential services for people living with HIV and at risk of HIV continue during the pandemic. Let's first describe these services to start with.
Okay, so we have we look at the services at different prongs. We have what we support at the facility levels. We have what we support usually at the community levels. And then we have various stakeholders who come in between there, ensuring there's adequate supply of commodities and all that happens. So really within facilities, we want them to continue to be open because we want people living with HIV who are enrolled into treatment to be able to continue to access their ARVs. Some of them are eligible for various tests in between, so they need to be able to have access to that kind of testing. Some of them are young children, perhaps children who are born to HIV positive mothers. They're still in care. They have critical vaccines that they should be receiving. So that particular kind of service at the facility continues to be very critical for those that are already HIV positive and in care. For those that are maybe HIV positive and not aware of their status, we need facilities to continue to remain open so that they can get tested. Yeah, so that someone can get into the facility, have a HIV test done, and if they're testing positive, then get linked to the necessary care. And then for those who are negative, then they continue to receive preventive messaging so that they continue to stay healthy. Same thing at the community level. We want people who are in the community to be aware that they should know at least their HIV status once every year, so that then once you get tested, then you get access to the right treatment. And then as well in the community, it becomes very critical to give messages around prevention so that those who are HIV negative continue to be HIV negative.
Okay, so these are the services that WHO and other partners have said have really been disrupted by the ongoing COVID-19 pandemic, not only in the country, but also across the world. But before we delve further into the status of Kenya in as far as HIV prevalence is concerned, if we can have those graphics on the screen. So far, according to the Ministry of Health, they say about 1.5 people in Kenya are estimated to be living with HIV today. Now, 41,416 new HIV infections occur in Kenya every year, meaning that 114 people are infected every day and 5 people every hour. Now, the main sources of these new infections is unsafe sexual practices and the mother-to-child transmission of HIV. Now, another statistic coming from the Ministry of Health is that 20,997 people lose their lives in Kenya every year due to HIV and AIDS, and this translates to 404 AIDS deaths every week and about 58 people per day. Charlotte, when we look at these numbers, are we concerned? Are we in the right direction as a country?
We are definitely concerned. We definitely want every life to matter. I think we definitely want to make sure that every person in Kenya, it is the mandate of the Ministry of Health generally to make sure that every person in Kenya, born in Kenya, actually stays HIV free and then actually lives a good quality of life. So the numbers are worrying. I think one of the things we do like to do as medical personnel is to see faces and people behind numbers so we don't get lost in the numbers. I would like to actually still highlight that while the numbers are high at this point, they've actually been higher. And we have made significant strides in actually bringing them down. Looking at the data as far back as 2016 thereabout, we had about twice the number, 3 times the number that were new HIV infections. So we are making significant strides. However, the COVID-19 pandemic has really disrupted our service delivery over this year, has really disrupted our HIV preventive services particularly. So we do look forward to mitigating these two together so that we do not reverse the gains that we have made so far.
Yeah. Emily Muga, you are the head of the Global Fund Program at the Kenya Red Cross, and of course, you are the custodian of the 14 billion grant that is catered for to cater for HIV and of course other infectious diseases. Are you concerned about these numbers?
Yes, from a community perspective, we are very concerned about the numbers and also the fact that the pandemic has brought in new challenges to access to treatment and also to prevention services that are actually being provided in the country. So some of the things we are worried about is adherence, which has gone down because of COVID. The communities are lacking food, basic food, to be able to adhere to treatment, because you must eat first to be able to receive your treatment and also take your pills on a daily basis. We are also concerned about the surge of the COVID-19 because most of the facilities now are being made into isolation center, reducing the number of facilities that we have to access these services. We are very concerned about the lower level health facilities where healthcare workers have been moved to support the upsurge of the COVID-19 and therefore reducing the access for especially the rural persons who are living with HIV and are living in the rural areas, and their access to facility is basically the rural facility. We are concerned about the gender-based violence and the intimate partner violence because of the restrictions and the fact that people have lost jobs. People living with HIV are at home and therefore they are not surviving. They are actually trying to thrive, but again, these are concerns that make them more vulnerable to new infections, that make them more vulnerable to sexual violence, and make even people young, especially adolescent girls and young women, very vulnerable to new infection, lack of access to prevention commodities, lack of access to facility, and also the general concern around the people's perception around going to a health facility, especially when you assume that you are well. So people are actually not going to the facility because of the fear of COVID, and in the process not able to receive their preventive commodities to reduce their vulnerability to HIV. So the Global Fund has brought in support to help us move people to awareness level and also to help us facilitate the people to move to the facility, and also to help us to facilitate facility staff to move to the community through outreach services and be able to provide services to the people. When the pandemic started in in March, the Global Fund provided reprogramming. In May, they provided additional funding, and currently they've also provided additional funding, basically looking at creating awareness, provided PPEs for people, ensuring facility staff can actually meet the demands for HIV for the community people.
All right, and we'll talk more about the stop-gap measures and, of course, some of those gaps that we've talked about further. Let me bring in somebody who comes from the metropolitan area, Elizabeth, and definitely we've talked about the effects of COVID-19, and the biggest is the economic impact of the same on those that are living with HIV. And as we are saying, Emily's mentioning, you need to eat before you can actually take this medication. What's the impact of the same in the urban setting?
Okay, the impact of COVID-19 in Nairobi and urban setting has really been a major problem. We can see even the TB area, our patient disappeared. They went away. We lost a lot of patients in this era of COVID because they had nothing to eat. You know, when you are sick and you have nothing to eat, you cannot take your medication. So this was a concern for us. A lot of patients went away. We lost most of them. Some were scared of even coming to the facility, saying that there is COVID, so they were very worried to come. And we all know that TB affects the lungs, and these patients are very sick. The lung is already damaged. So coming to the facility for them was really a very big task. So we had also to strategize and see the best way to ensure that they get the services. So most patients are not coming. We see patients, and you know, TB is affecting the low. We can say the people who don't have the economy has really affected. Patients are not coming. They are thinking they need to eat first, yeah, before taking the medication. So for us, this has really impacted us in the TB world.
Okay, and do remember that TB is an opportunistic condition when it comes to HIV, and that is why we have a representation from somebody who understands TB and the impact of the same, especially in the face of the pandemic. Now, with the resurgence of COVID-19, at least what they're calling the second wave, how has this affected service delivery and access of the same for those living with HIV across the country, especially in the rural areas? Let's hear from Dr. Cornelia Ochola.
Yes, as been mentioned, there has been the patients have really been affected by COVID-19 as in the rural areas. One of the things that has happened is the transport to the facilities has become an issue because of the raised transport costs. So you find patients have a challenge to get to the facilities. For them, just the fear and lack of awareness of what COVID-19 is, and it's linked with HIV. So again, certain patients will find that they are afraid to come to the facilities because of these particular challenges. Certain things that also affect them is that there are people who are working in the rural setups, and because of COVID-19, they lost their jobs. So they're not able to continue staying in those particular areas and have been forced to move to other areas, probably back to their home areas. And so that has also affected their access, because now they have to move from one facility to another, and that has affected their access towards the facility, to coming to the facilities. And those are some of the challenges that have really come and affected the access for the patients to come to the facilities.
Okay, and how about the access to the facilities? We've heard a lot of the facilities have been turned into isolation centers. Is this the same thing going on in the rural areas when we talk about the small facilities like the dispensary where somebody can go and access their ARVs?
Yes, that has been a challenge in that there have been facilities whereby, for example, you find that a facility has been converted to a COVID-19 center. And so, for example, us as implementing partners working together with the county have to think very fast and try and find other areas where the patients can access the services, and that at least has been able to ensure that services the patients are still able to access the services from different areas within the facilities, but also helping with community ART. Also, that has helped to ensure that services also continue, although that has also affected. What has also affected is that sometimes you find that healthcare workers also or people who are working within the facilities get COVID-19, and so the facility has to be closed down for a particular period of time so that also disrupts services within the facility. So we've seen that happening in different health facilities. However, the county, together with implementing partners, have been able to work together to be able to ensure that services continue, even if it means transferring the patients from one facility to another for a short period of time before the issue is resolved in their previous facility.
Okay, let's talk to somebody who understands how this shoe pinches. Judy, you have been living positively with HIV since 2007. What are the challenges the pandemic has brought your way, or others living with HIV?
Yes. The first challenge we have come across as people living with HIV, it has been very difficult to us to access the health, to go to the health facility due to lack of transport. And to some extent, most of us lost their job, so it's become a challenge to us. And in other words, some stop even coming to the health facility because they are afraid, because those centers were left for, they were set aside for the COVID centers, COVID centers. And it has bring a lot of problems to the community.
Okay, and when it comes to, for example, the services to do with counseling, and especially for mothers and all, have these been ongoing, at least on the community level, to compensate for not being able to access the health facilities? Do we still have Judy? Okay, we seem to have lost Judy, but we'll get back to her to understand exactly what those living with HIV are going through, especially in the Siaya area of this country. And the WHO, UNAID and other stakeholders in this space have pointed out that the breakdown in essential HIV services in the pandemic is threatening the gains made to fight the HIV epidemic, especially in sub-Saharan Africa. Charlotte, what is Kenya doing to ensure that we avert this narrative?
Okay, so the most critical thing becomes taking care of those already in care. And I think my colleagues have actually highlighted some of the things that we've done. Again, in trying to mitigate the effects of both, we had facilities that had to be made into isolation centers to allow for care for COVID-19 patients. So we quickly began to innovate around how to make sure that people living with HIV can access care, because then they need to access care, they need to be on ART for them to be virally suppressed. So that becomes really critical, that they must remain engaged in care. So some of the initial guidances that came out from NASCO particularly were around healthcare workers dispensing ART for a longer time. We have a supply chain system in the country that allows a month, 2 months or 3 month ART refill. But at the beginning, we a bit flexible, allowing 3 months for across the entire subpopulation, except for particular ones, especially newly diagnosed HIV pregnant women who we felt needed a bit more care. Infants were given a bit less, but for the longer part, for the initial longer part of the epidemic, we had healthcare workers actually allowed to give people living with HIV longer treatment appointment dates before they could come back. In addition, we mobilized for what somebody mentioned, which are called community ART groups, where a peer person could pick ART from the facilities and then distribute to people from their homes. That now takes care of the cost of transport, so they don't have to actually come to the facility for that. Then they're taken care of from home. Some benefits that people living with HIV actually have when they access facilities is psychosocial support. You know, that peer support from someone who's living positively. So we try to arrange for some of that to happen virtually. But again, like we're talking about in the rural setup, I mean, not everybody has connection to internet. Some of the things we take for granted in Nairobi are not actually accessible in Siaya, in Homa Bay, and some of the counties that are far reached. So we tried to do as much as we could in that area. We did, there were some limitations in terms of particular procedures such as elective voluntary medical circumcision, that's a preventive, for a particular amount of time. But later on, they were sort of allowed in a stepwise manner just to make sure that those who can access the services get them, so that they have the protection from actually acquiring HIV infection. And then there are other modalities around HIV testing, like HIV self-test kits that don't require you to sit down with a healthcare worker to test you, but with some guidance within the leaflet, the package, you can actually then access a HIV test even from the comfort of your home. So those are some of the things that we are trying to innovate around. It's not been easy. We need more innovations to come in. We need a bit more funding, especially for virtual platforms, to be able to do some of the trainings that would have actually been able to do physically, so we can be able to undertake them virtually. So there's still room for us to innovate and come up with ways that are able to mitigate the effect of the pandemic.
Okay, before we get to the funding point of view, let me hear from Elizabeth one more time, and this is about the opportunistic conditions we are talking about, especially TB in this season. How can we keep those at bay, because we have all these other challenges we are talking about? So how are you catering for those living with TB in this season?
Okay, thank you very much. It has been a challenge, as Dr. Charlotte said, but we had to innovate new ways. And Emily said we got extra funding from Global Fund, so we have gone community way. We did a lot of community work. We are going to screen even at the community, and this is targeted when we get an area, a population where we have a lot of TB cases. We do community targeted screening. For our patients, especially those with drug-resistant TB, we have gone community way. We are taking the drugs to them in the houses because their lungs are damaged. And if they come to facility, they interact with so many clients and so many patients. We don't want them to suffer COVID. We had one patient who suffered COVID and he had drug-resistant TB. It was not easy. We are also extended this to the patient who have normal TB, which we call drug-sensitive TB, to do community treatment. And another thing that we have done to our patients, we are giving them a longer return date. Not the usual return dates, and this was from the national program, TB program, so that we give them a longer return date, so the refills are at least a month, so that the patient can also go and not visit our facilities regularly. The patients that have drug-resistant TB, we usually review them. It has been a challenge. So we have had a virtual meeting just to discuss this patient, how best can we manage them, because they are reviewed by a multidisciplinary team and it requires an physical meeting. So we could not have them. We had to go virtually. Our HIV patients who have TB, as Dr. Charlotte said, adherence was very critical. Those who had not adherence, we are finding them to coming back with a resistant type of TB, which is also very critical, and the patient are going down. So these are the patients that need more attention than those who are not HIV positive. So we have done a lot. Even we have a call center just to ensure we educate the community about TB. They can also do self-screening by just dialing *371# to know their TB status, and they'll be referred to a facility where they can get more attention. Yeah.
Okay, and that is what again,
*371#. This is self-screening that you can do on your phone. It only costs a bob to do that. We have our call center also. For the patient that are having the signs and symptoms of TB, you know, TB and COVID are very similar because there is also cough. But one thing with the cough of TB is a productive cough. There is weight loss. Yeah, there is night sweat, which is specific for TB, and the fever is low-grade fever. So if you have such a sign, we have a call center that we have our healthcare workers 24 hours. You can dial 0800-722206, and you'll get the services, you'll get more insight about TB. Yeah.
Thank you, Elizabeth. And you will tell us if these challenges are being seen more in the informal settlements, rural areas, or even in the modern setup in a moment. Let me hear from Emily. Definitely the importance to focus on other diseases during this pandemic are very critical because, as we know, those with underlying chronic conditions are very susceptible to contracting COVID-19. So how can we ensure that the conversation on eliminating and managing these other conditions continues even within this season?
Okay, yeah. Other chronic conditions are a key factor, and we really need to look into them. One of the challenges is that many of us in Kenya live with chronic conditions without knowing. So one of the things that we must do is create awareness around the other conditions that are available. We need to do screening, regular screening at community level to identify the people. We need to provide the personal protective equipments, especially the masks. We need to train them on how to prevent themselves from COVID, avoiding crowds, keeping distances, wearing masks, washing hands all the times. And basically, we need to ensure that our health facilities are well equipped and well prepared to take care of those who need services, even in this time of pandemic. One of the concerns that people have at community level is that when you arrive in the facility with a breathing problem, the assumption is always COVID, and that is a community assumption. So many of us who have other conditions do not want to talk about them because you might end up in an isolation ward. And therefore, it is important for us to do a lot of community sensitization, a lot of information provision, because people make decisions based on the information they have. So the more information we can provide, the better. The more we can go to community level and start working from the primary healthcare perspective, ensuring that the community health workers have the information, the peer educators have the information, and they're able to make informed choices, and they're able to seek treatment and to seek preventive measures as and when they require, the more healthy we will be as a community. We should not forget that health is a human right, and we have people who do not even come to health facility because of fear of discrimination. These are the population that we work with that are either key population, men who have sex with men, people who inject drugs, female sex workers, or male sex workers. And how do we then ensure that they can actually get preventive measures, because they are not a cohort that would not get co-infections. They do, because most of them end up with STIs, and this is a co-infection that makes your immunity go down and make you vulnerable to, of course, other infections, including HIV, including COVID. So for me, a lot of community sensitization and a lot of our work should be in community to ensure we prevent people from at the community center, so they don't have to go to the health facility and meet with the older people and with their mothers. For the mothers who are expectant and having children, they need to get all their services at the maternal child health clinic, so that it is a one-stop shop where they get all the services that they have. For the person living with HIV, when they get to the CCC, they should get all the services that they require. But before even the services, prevention is the key.
Okay, as they say, prevention is better than cure. Now, even as we mark the World AIDS Day on this first day of December, there are some statistics still coming from the Ministry of Health, and this one is actually the county distribution of new HIV infections. And it is interesting that the change in the number of new HIV infections across the counties between 2014 and 2020 shows that 7 counties that included Nairobi, Lamu, Marsabit, Bungoma, Kakamega, Busia, and Vihiga are on a reverse gear, having registered increased number of new HIV infections. Now, however, 21 counties are on a forward gear, having reduced the number of new HIV infections by more than 50% of the same period. Now, that list of counties you see are the ones who have registered minimal decline at around 50%. So they are on the right track, but can still do better. But there are those counties that are really doing very well. And in this case, we have seen large improvements when it comes to the same. And these are Kwale, Makueni, Tharaka Nithi, Nyeri, Nyandarua, Kiambu, Murang'a, Kirinyaga, West Pokot, Bomet, Kisumu, Homa Bay, Siaya, that is being represented here by Judy, and Nyamira, amongst other counties. So this is the status in as far as new HIV infections in the country within the counties is concerned. And now that we have a representation from Siaya County, I think we have Judy back. Now, those living with HIV are among the vulnerable populations susceptible to contracting COVID-19, as we have said, and definitely the severe form of the same. How are you ensuring that communities ensure they safeguard themselves from contracting COVID-19, Judy?
Okay. With this one, the CHV, the community volunteers, they work from door to door, sensitizing the cleanliness, the importance of putting on masks, the social distancing, and not being in the community gatherings. They are also told to wash their hands regularly with the soaps, with the running water, and to avoid overcrowded places.
And you are an ART, therapy treatment supporter in Siaya County. How are you ensuring to reach out to, for example, the mothers, expectant mothers that need to adhere to their medication while pregnant, and even those that continue on the same after delivery?
This one are the pregnant mother who came to the health facility to access their services. They came when they're pregnant and they're being tested. They're tested. The major point there, they're being tested after knowledge of status. Once found positive, you enroll to HIV care, and there you'll come regularly on antenatal care on a monthly basis. There they will be given their ARVs, ARVs classes, accessing how they have taken their medication, and if disclosed, he or she will be encouraged to disclose to the family partners.
Okay, now reports are saying that a lot of mothers have opted to have their children at home. Some that are not even going for their regular clinics in the facilities because they are afraid of COVID-19. How are you being able to reach out to that mother who has said, afadhali uhai, sitaki kwenda hospitali?
Okay, this one we know them, we have registered them, so we just conduct the home visit. You go and discuss with her the importance of visiting the health facility. And if she comes to any challenge, you discuss, you talk over that challenge, you encourage her the importance of coming so that she can come, because with pregnancy, you can develop other complications. So they need to be attended at the health facility. We encourage them every point, even we send the CFWs who are coming within the villages where they're coming from.
Okay, and adherence to the drugs, the ARVs, is so critical. And with people scattered all over the country because of the impact of COVID-19, how are we ensuring that we keep those networks working to ensure everyone is adhering to ARVs?
Some we get from their self-reporting, and others we can do the field count. Some with the issues of with adherence and non-adherence, we'll conduct the home visits. I, as a mentor mother, will conduct the home visits. Maybe the adherence counselor will accompany me, or the healthcare provider will accompany me, so that we can go and check what is happening at the home level, so that we can also help her to accept HIV status, because some of them, they are tested while they are pregnant and they have not accepted the HIV status, they have not disclosed, and that one becomes a challenge to them, and it's making them not to adhere to their drugs. It becomes a challenge even to the health facility when some decided not to come to the health facility and they just decide to give birth by traditional birth attendant, which we do not encourage nowadays, because there are some challenges which can come during the delivery.
Yeah. Okay. Thank you, Judy, for the work you're doing, and we'll understand further in as far as what it is that you do. And Dr. Ochola, how can all these efforts we speak about today keep those living with HIV at the front and center of safeguarding their well-being in a pandemic?
So we are asking how we can ensure that the efforts that we are doing keep these people at the center.
Yes.
One is like what we are doing with Judy right now, intentionally involving the people with HIV in the decision making, bringing them to the seat, so that we're able to understand what exactly what kind of services would they require, and for the different subpopulations. This would be for the adolescents. So you bring an adolescent who will be able to ask them, what would we do to provide services that are good for you, that will be acceptable for you as an adolescent, so that you're able to come to the health facility and access services. So by this, we've been able to come up with different innovations. For example, for the adolescents, we've been able to have adolescent peer mentors who are able to interact with their fellow peers, especially now these adolescent peer mentors, adolescents living with HIV and are doing well, and they're taking their medication well, they are suppressed, they come for their clinic appointments. So you find that when they speak to the other adolescents, you find that these adolescents also do well. They're not afraid of of coming to the health facilities, even in this season of COVID-19. Another thing that we are doing is that we are able to sensitize the people living with HIV, for example, on infection prevention services. So, for example, we're able to talk to them about the washing of hands, the wearing of their face masks, and also how to be able to protect the healthcare providers, providing PPEs for them within the facility. And so we are able to ensure that as they come to the facility, they're not afraid of the healthcare workers, and also the healthcare workers are not afraid of the patients who are coming to the facility. So services are being offered in a good way for these particular patients. Another thing that we are also doing is ensuring that we are doing the screening for COVID-19 within the CCC. So integration of that. And if you find somebody who, let's say, is has symptoms, we're able to ensure that further tests are done in a way that is not discriminative, in a way that is sensitive to the patient and also to the healthcare workers. We are also ensuring that, for example, when the patients are coming to the facilities, there is no overcrowding. We've heard about the community ARTs. So the patients who are stable and are doing well, they are able to come to the facility and take their medication in a fast track way, meaning they take their medication quickly and they're able to go back home and continue with their business. The ones who are getting community ART, so a peer comes, takes the medication and goes and distributes it within the facility, within the community, so that there is no overcrowding within the facilities. We're also doing the social distancing within the facilities. So it's not like before where you'd find we have 50 clients who have come to the facility on the same day. So what we do is that we have spaced the facilities, there is good aeration. We are also staggering the appointments. So a patient will be told, today you will come at 8, another one will come at 11. So in the course of the day, the crowding within the facility is not there. So that also helps with that. And so that has helped allay fears of the people living with HIV about coming to the facilities and accessing care, and also trying to ensure that the services that they had initially continue. So we've talked of virtual services that we are offering to the care, to the patients. As said, not all of patients have smartphones to be able to get virtual services, but we are also just making phone calls. So you find within the facilities, the healthcare workers, the peer mentors have become what we call case managers. So they're able to call the patients and ask them, how are you doing? Are you taking your medication regularly? Not that we're not having the psychosocial groups, but they're able to reach out to them individually to ensure that the services are still offered even on an individual basis, and they're able to access, continue adhering to their medication. And we find that we're able to continue maintaining viral suppression with our patients. So innovations are different for the different populations, different for, let's say, the adolescents, the pregnant women, for the young girls, for the key populations. So we are trying to ensure that the innovations are subpopulation specific and what will answer to their needs in this particular pandemic.
Okay, clearly this calls for a lot of rethinking, re-strategizing and innovation as you speak of, even as we face the pandemic, and of course ensure that we keep those numbers of HIV infections on the low. Now, earlier on, I'd asked you on the question of the day, do you know someone or are you living with HIV? What are the challenges of accessing medical care during this pandemic? Please talk to us. That hashtag is new normal. We have Lillian who says, I know quite a number, but I haven't gotten in touch since the pandemic, but I trust they are doing well because they are usually handled by a very dedicated social worker. The importance of social workers, community health volunteers, very critical at this time. Evans Afwodi who says, folks will not be bold enough to disclose their status regarding this. Well, that is something else. We'll be talking about the stigma around the same. Emma Mkutano, there are so many, but the challenges are there. Are there Septrine for the opportunistic infections, and most of them can they afford to buy? I think that is a question, Emma. We hear you. We'll be talking about that in a moment. Charles Toroitich says most people living with HIV whom I know don't want to believe that they are infected, so most of them use alcoholic and other drugs that can make them forget. Charles, that is a very sad state of affairs, and we'll be talking about the importance of getting rid of the stigma that is part and parcel of us many years after HIV became a reality in the globe. For now, we take a short break on Your World. When we come back, more about this World AIDS Day, the 1st of December. Stay with us.
Everybody!
Do you need
to send your parcel or document during this period? The Nation Courier Services, with over 15 years of distribution experience, will deliver it for you. We deliver to every corner of Kenya. Due to our strong distribution network, have overnight door-to-door service and same-day intra-city service with the security and safety of the client's shipment guaranteed. Your parcel is our priority. We'll deliver it for you. Contact us for delivery on courierservices@ke.nationmedia.com or call 0719 038 739.
Yes, Max. I will marry you.
Na hiki tumechorwa kwa mgongo yake ni map ya penye Brian amefichwa, si ndio?
Paul.
Boy wangu, wewe ni mfani mbaya.
Sikuwe fani zaidi basi nikikutoa hizo meno zako imbo.
Wenye mrembo hivi na mbona kuje ni mali.
Wewe, umefanya kazi?
Job nilishamaliza kitambo. Unipe maziwa yangu sasa.
Babe. Huyu kijana si ndio yule alijaribu kunigonga na gari?
What a relief! Thank you, Gold Crown. If regular milk makes you feel uncomfortable, try Gold Crown lactose-free milk. Milk that loves you.
Every spoonful of Nutri comes loaded with the necessary vitamins, protein and minerals for you and your family to become healthier and stronger. Pick up a pack today from your nearest store. Nutri. Every spoonful counts.
Thank you for staying with Your World. My name is Gladys Gachanja on this first day of December, which actually marks the World AIDS Day. This morning, we are taking stock of how Kenya is doing in the face of the pandemic. And I'm still joined by my panel this morning in studio, Dr. Charlotte Paherogo. He's a pediatric adolescent technical advisor at NASCOP. We are also joined by Elizabeth Moini, who is a county TB leprosy coordinator at the Nairobi Metropolitan Services. Dr. Cornelia Ochola joining us virtually, she is the HIV technical lead at the Center for Health Solutions Kenya. Emily Muga, head of Global Fan Program at the Kenya Red Cross, joining us from the comfort of her home. And Judy Atieno, who is a community antiretroviral therapy treatment supporter, joining us all the way from Siaya County. Thank you, ladies, for staying with me on this one. Before we continue with this conversation, there's something that was that came up from the feedback. If you can have that feedback back on screen. Emam Kutano, who says it's not grammatically correct, but he is saying there are challenges out there, especially when the availability of Septrin and other medications that are important for those living with HIV. And what is the status, Charlotte? What are we doing about this?
Thanks, Gladys. So what happened for the previous years, we had a donor who was supporting supply of Septrin to the country in addition to the ARVs. And so towards the end of somewhere mid last year, they let the country know that due to the declining donor funding for HIV, particularly globally, then there's going to be a reduction. So then they will not be able to take up that. However, since then, the government actually has made efforts to take up the cost of that, to buy it and to make sure that there's supply for people living with HIV. However, the processes with negotiating with manufacturers sometimes take some time. So you're asking for doses of Septrin that are taken daily for 1.5 million people living with HIV. So you're asking for bulk, a lot of doses. You have to make sure that the manufacturers you're asking for are meeting the particular standards for manufacturing the drug. So that has been done, and I think part of the negotiations that have actually been done is to identify local manufacturers to quickly supply and sort of be a stopgap for some time as we sort out the international supply in between there. So from what I know, there should be Septrin by the end of the country available for people living with HIV. However, and I agree with their concerns, is that they've had to sort of bear, for those who particularly needed it in that particular time, they've sort of had to bear the cost, but that will be taken up, and it is a priority for the government. Yeah.
And Emily, how are you helping along the process of ensuring that there is constant medication for those living with HIV in the country now that we have the grant with us?
Yes. Gladys, our supply chain is the national supply chain, which is KEMSA. The way, what we are able to do with the community is we are able to move the medicine from the facility to the community level, and at times, especially for the key population, from KEMSA to their facilities, which are called the drop-in centers. But in terms of moving medicine from international suppliers or manufacturers to Kenya, that is even under the Global Fund program, it is a mandate of the state principal recipient, which is the National Treasury, working with KEMSA. So our role has always been to ensure that the local medication that the country has brought in, and also to ensure that our facilities, which is the key population facilities that are run by non-governmental organizations, also have access to this particular medication. The other thing we've done is also to create community ART groups that we are talking about, and then we've been able to ensure that their refills are done, whether it is by in-person or by facilitating the healthcare workers to move into households or to move into community groups and have meetings at particular time in a particular place to be able to refill their needs. But when there is no septrin in the country, then our beneficiaries suffer the brunt, because we depend on the country supply system to be able to receive this medication and to be able to provide them to the population at community level.
Okay, let's hear from Judy. How is the situation in Siaya County as far as ARVs is concerned? Is there a time in this season where there was an interruption of the same?
No, we have the supply. The supplies is with us constantly. We have not even missed the drugs within our facilities, and our clients are also accessing the medication on time.
Okay, we are saying there is there is a lack of septrin in the market. Is this something that you faced?
Yes, we also faced it in this side. And some clients who are used to the septrin, they're asking the healthcare worker if they can buy, but if they can buy the septrin so that they can use it, because they used to take it with their ARVs. So they are being advised, if you are capable, you can buy, they are buying it. But those who cannot afford it, they're just taking the drugs alone.
Okay, and we have assurance from NASCOP that we shall have it in the market by the end of the year, which is in a few weeks. And I'd like to understand also, Elizabeth, when it comes to TB, have you had an interruption of the drugs that are really critical in managing the same and treating the same?
Thank you very much. For us, we don't have issues with supplies of anti-TBs. The only thing is the drug-resistant TB, where when we get a client, we need to have an order from the national program, from KEMSA, which takes within 1 to 2 days to get the drugs. But the normal TB drugs are available at the facilities. In fact, as I talk to you, we have a supply of 3 months for now. Yeah.
Okay. And even as we continue to talk about rethinking strategies, reimagine systems and devise new innovative ways to combat HIV and COVID-19 pandemics and epidemic in that order, is the underlying message of this World AIDS Day possible when it comes to testing? You talked about self-testing.
Yes.
How is that possible for every Kenyan in this country today?
Okay, so and I hear your hesitation.
Yes.
So the thing about testing particularly, and maybe I can highlight what the guidelines are for the country, is that generally we want every Kenyan to know to have a HIV test every year, at least every year. There are other situations where people require to test more than once a year. So they differ with either when you're pregnant, a particular situation, if someone is a male sex worker, if they're a key population, for instance, those ones might require to test maybe a bit more frequently. So what happens is that within facility setups, we tend to get this same sort of people showing up every year having a HIV test. But when we look at our data, we realize over time, we are not really, there's a niche of people we are not reaching. There's a niche there's a subpopulation up there of people who need to know their HIV status, and we don't know them. So what happens is, while we have about 1 million people living with HIV already on care and on treatment, we have about 300,000 people we are not able to reach. So while and then we realize that while we've done everything at the facility, done everything at the community in terms of referring them to the facility for testing, that strategy doesn't seem to work for them. And if you look at it on the other way, we have Kenyans who don't, why would I go to a facility if I'm not sick? We have Kenyans who work, they sleep during the day because they work at night. So then facilities are closed. They work during the weekends, so their facilities are closed anyway. So what the HIV self-test was about was trying to reach this niche of people we can't reach. Because if you think about it, in a country where you have a prevalence of 5.6%, you're looking at 94% of people are negative, and then you have this 5.6% that are HIV positive. But then you're not worried about the person who's HIV positive and in care. They're virally suppressed, they're doing well, they'll be okay. So you're worried about this person you can't reach. And the person who does not know their HIV status, if they're HIV positive, they're going to transmit it. That's the reason why it is very key that you identify them very quickly, because they're out there not knowing that they're HIV positive. So the self-test kit was meant to reach that particular gap. And one of the, I'm smiling because one of these key people that were difficult for us to get were men. I'm smiling because there's one seated right across from me, and I do not want to offend him. So we're trying to reach these young men who are otherwise fit, otherwise doing well. They have no reason to go to hospital unless they're involved in an accident. So why would a man show up in the facility for nothing? So is it possible that if I availed a HIV test, that they could do the test by themselves in the middle of the night at 2 a.m. when he's done with everything, and then there's a stepwise approach on what to do in that thing? Could he possibly just do that? And then there's a guy that says, in the event that it tests positive, call somebody on this number, then they'll lead you to what to do next. So could that possibly help me identify the gap? Because for you to be able to reach that epidemic control, and for you to be able to reach the last person, if you want to keep the rest of the population safe, you want to reach that very last person who does not know what their HIV status is like. So it wasn't really meant for that entire mass testing and everything. It's meant for this niche that you can't otherwise get. So yeah.
All right, Dr. Chola, even from our feedback, in this day and age, we still have a lot of stigma around HIV and AIDS. How then can we ensure that we come up probably with innovations to ensure that we still do the testing and people still are part and parcel of a bigger community that lives positively with HIV?
Yes, that's very important, and that's something that we see every day with stigma and discrimination still happening in this day and age. However, how certain strategies that we are implementing to try and reduce that is, one, stigma can be in two ways. There can be self-stigma and also stigma from the community or the people around the patient who has HIV. So for self-stigma, it's just about ensuring that we have treatment literacy. When a patient is identified, ensuring that they get treatment literacy, they're able to understand HIV, know that HIV is not a death sentence and that there's treatment for this. And if they take their medication well, they're going to do well. And this also helps them to be able to disclose to their partners, disclose to their family, so they're also able to get support from people around them to ensure that they are able to adhere to their medication and continue doing well. Also now, stigma from people outside. This comes about what we are doing to assist in this is, one, advocacy, and also just community education about HIV. So one of the things that people are doing, you've seen different campaigns just for people to, one, know their status and being able to be educated. We've seen different campaigns for this, like Jipende, Dijue Jipende. We've seen different strategies that have come out from this. So one, being able to know their status, being able to educate the community about HIV and know that HIV is not a death sentence and that people are able to take their medication and will do well with it. Being able to support the people around them if they have HIV, that being able to teach well about how HIV is transmitted, and that when you sit with one person within a house, HIV will not be transmitted. If you use the same cutlery with someone who has HIV, one will not be able to transmit HIV through those means. And so with this, we are able to at least reduce stigma and discrimination around, and also just build support. Another way that we've been able to reduce stigma is also just cross-sectoral involvement. So, for example, just an example is our adolescents and our children, whereby we've been able to work together with the Ministry of Education and being able just to educate teachers about children living with HIV and how they can provide assistance for these particular adolescents and children within the school setup, and just reduce stigma and discrimination around there, so they're able to take their medication when they're at school and being able to do well with that. Another thing is also with the community, being able to create awareness and just advocacy within the community, with the community leaders, with the political leaders, so with our community leaders, and just being able to ensure that they help us in the fight of HIV. So we've had engagements, for example, with first ladies within the counties, where they've been able to support the HIV/AIDS agenda. And this also helps to reduce stigma and discrimination, because when you see a prominent person there and saying, we can fight this, we should support these people, they should take their medication, especially for the adolescent girls and young women, being able to support them and ensure that they get their essential services, for example, sanitary services, and also are able just to access their medication well, you find that they end up doing well and also reducing the stigma around where they are at. So those are some of the things that are happening.
Okay, and for you, Judy, you've been living with HIV positively for 13 years now. If you can compare today and when you were first diagnosed, how has life changed? Are we doing better in as far as stigma is concerned, or we still have a long way to go?
Okay. Me, it was very difficult at first time around at that year 2007, but nowadays I'm living positively and I've accepted and moving on, because I've accepted my status, even I've disclosed even to the community, to my partner, to my close friends, even to my family members. And that's why it is becoming much easier for me even to say that I'm HIV positive, regardless of where I am, and just speaking about my status.
Now, as a woman, is it difficult to be able to preach the same message to the male counterparts?
Yeah, to some extent, because some will just say that you want to say that me, I'm HIV positive, but with him, he has another agenda with you. Even if you said like that, he'll just say that you want to stop him somehow, in another way. He will not accept that you are HIV positive. But the more you keep on, even the drugs you're free to take, even where you are, he'll just accept. He'll just say that she is HIV positive. But to some, it won't be easy for them to accept.
Okay, now in these communities that you are part of, do we see more men, or are we seeing less of them, or has that changed over time?
Okay, to where I am, there are not more. We are many in number. We women, we are many in number, because I don't know how the understanding of women and men might be much easier than the understanding of men. Even getting them is not easy.
Yes.
For them to come to health facility is also a challenge, and that's why they are fear in the system where we are taking our medication.
Okay, and when it comes to does this affect the adherence of ARVs or treatment in this case?
Because there are few, or what?
Yes. Do you have a harder time trying to encourage the men to keep taking their medication and being part of a larger community?
We do encourage them, because they have their people to look after, so they can even disclose to their fellow colleagues. That one can help them to plan their life. That's why we do encourage them to speak about their HIV status. And some who are willing to do so, they are living positively, and their family, they are pushing on well. Even their children, they can bring their children for HIV tests. That's why we do talk about that. That's why we do encourage them to bring them to health facility. And some few men who are hard to understand even the word HIV, the word knowledge. Why do you come to the health facility to know their HIV status? They need time. They need time for discussion, and that's why we do go to visit them there. So the antenatal mothers, those who came for their first visit to the health facility, for their husband to come for knowledge of sex, it will be very difficult. And that's why this idea of Quick, that self-testing is good. It is helping them. They can come more free to their partners.
Yeah. Okay. And Emily, when it comes to stigma, you mentioned a certain key population, the LGBTQ, when it comes to the prevention and, of course, treatment and management of HIV. Now, this is a group that says they continually feel stigmatized and at times forgotten when it comes to the strategies of the same in as far as HIV and TB is concerned. How do you ensure that they are included in these dialogues?
Yes, for the key population, we normally have a three-pronged approach to reaching them. One is through their peers. So when you get to know the ones who are now living positively and really have an understanding of themselves and are able to and willing to stand up for their colleagues, then we take them through trainings, including trainings to be peer educators, trainings to understand HIV, treatment literacy, and trainings on advocacy. And then we facilitate them to be able to move from hotspot to another hotspot and reach their colleagues. So they normally snowball to reach their other colleagues. The other one is also to reach them through their wellness centers, because they have drop-in centers and wellness centers that are actually supported by partners. And really, in collaboration with NASCOP, we have set up quite a number of centers that support the key population. And so these are centers where the key population themselves, who are trained as clinicians, are able to provide services. And so they get referrals from the peer educators to come to these facilities and be able to receive all the services, because these facilities have been accredited by the national government and have MFL numbers. And so they actually essentially get their medication from KEMSA like any other health facilities. And the third approach we do is also what we call mobile outreaches. We have mobile vans that go around the community to the different hotspots based on the hotspots that have been mapped out with these particular people we call peer educators. And then we mobilize through the peer educators and they go to those hotspots and provide all the services. And in those services, they actually also tell them about the other facilities that are available to them in the drop-in center, so that they could visit the drop-in centers. We provide information, and we actually make sure they get clinical services and also look at issues around human rights and also the legal aspects of it. We also provide them with training as paralegals, and they are therefore also supported to ensure that the human rights of this population is well taken care of. And if they need support, then we also then provide that kind of support. Lately, because of COVID, we have also moved this to online support. So most of our facilities are able to then provide online services when they are required, both preventive services and commodities, and also the clinical services, so that the referral is only for those who actually must reach the facility, and their first stop is always their drop-in centers. And if it is something that they need a major facility to provide, then we do a targeted referral to specific facilities that we already have an understanding, and they are more supportive, and we've trained them on how to take care of the key population. Thank you.
Now, Elizabeth, when it comes to TB, it has been said that there is a prevalence of the same in men more than there is in women. Is this something that you actually are dealing with, and especially the stigma that comes around TB in a pandemic?
Oh, thank you very much, Gladys. Yes, men in TB are one of our major key population for TB, because you'll find that out of all the total patients that we have, more men are affected by TB than women. So we take this very seriously, and we have been trying to see how best can we get these men so that we are able to screen and test them for TB. Yeah, we have done a lot of industry work at workplace screening and testing, which we have gone there just to educate the team that is there. We do screening and we do testing. We have been doing, I've just said the self-screening app that we have, the star 371 hash. We have really popularized this app so that men can screen. And when they screen, then they get a positive. They choose a facility where they are going to go and they are going to be received, and all the services are going to be fast-tracked. Then we have gone to the community where we find men that are crowded, the drinking dens. We also educate them and also screen. So our aim is, where are men? So that we go there, we screen for TB, and we provide the services. Even those that we are having that have TB, we give them priority, which is their best time that they can come and pick medication. Some, they are going to work very early, at 7, so they talk with the healthcare worker, what is the best time they can pick, so to ensure that in the facility we have a healthcare worker who is able to give them medication at that time. If they can't make it in the morning, we have the evening, yeah, so that the evening time, the healthcare worker will wait for this client so that they get their medication. So these are some of the things that we have done. We are doing screening at the workplace. We have gone round at the community where we can get men. We give them services there. We have even gone to like Boda Boda where they wait. We give them the services. We tell them they do self-screening. If it is positive, if they have a cough, weight loss, we give them referral and we fast track their services so that they don't wait. Yeah, so those are some of the things that we have done, and we are urging the men, because TB is more rampant in men because of the social factors. Yeah, they need to screen, they need to come, we give them priorities so that they don't wait at the facilities, they get their drugs and they move. If it's testing, it's the same. We give them priority, they are tested, then they go. But we're having an issue at this time of pandemic because most people have lost work. So we are going to the community to see where we can get these men, and we do a lot of screening and testing.
Okay, thank you, Elizabeth. And even as we take another short break here on Your World, I'd like to get a feel of what you are experiencing, even as we asked you that question of the day. Are you, or do you know somebody who is living positively with HIV? What are the challenges of accessing medication or treatment during this pandemic? And Kerich says, yes, one has to travel long distances to get to facilities where they can get medication. We hear you, Kerich. Victor says, currently I have my mom and she's doing really good, having been living with the virus. Thank you, Victor. Kelvin Mungai says, these numbers are heartbreaking, more so the age hardly hit. Now, the society and the government of Kenya needs to do something ASAP. I think this is in relation to the status of HIV in the country. Dedan says, money is the real problem because they've been sacked from their jobs. Dedan, we hear you. King Twain says, it seems there won't be a vaccine for HIV and AIDS, but the old school stigma is gone. The sick should ensure they are on medication to lower their viral load and avoid spreading the disease. Just take medicine and live a normal, healthy life. Linus Morogo says, do not worry, BBI will solve everything. Linus, really? At this point, taking personal responsibility for your health and, of course, the stakeholders to ensure that each and every person living with HIV is catered for in as far as the services offered to them is concerned is so important, even as we mark the World AIDS Day on this first day of December and in the midst of a pandemic. We'll be back in a moment.
Malkia siku njema na tunukiwa offers kila siku.
Piga *444# utunukiwe Credo Double, double!
Sumo Premium Candles. It is made of pure, fully refined paraffin wax. It doesn't have smoke. It has long burning hours. It is non-drip. It doesn't smell.
Always smile and work with Sumo Candle from Rock Industries Limited. For inquiries, visit our offices at Ndume Road off Lungalunga Road, behind Carton Manufacturers near Sinai Stage. You can also talk to us through 0722 575 619.
Chrissy Bila worries. Chrissy na Naivas is now on with the biggest and tastiest offers this festive season. Every day, 350 winners Kula shopping voucher worth 2,000 shillings. All you need to do is simply present your Naivas card when you shop for your chance to be one of the winners. Naivas saves you money.
I heard about the Equity Wings to Fly program. I applied and I was able to get in. They paid for everything, literally everything that I needed. I'd like to start an initiative like the one Equity started here to sponsor students.
Equity. Bega kwa bega.
Rock Industries Limited wanakuletea bidhaa za plastiki zinazotumika kila siku maishani, kuanzia matumizi ya jikoni, usafi na shuleni, miongoni mwa matumizi mengine. Chakula kitamu sio upishi tu, kikiwa kitamu kisha kipakuliwe katika vyombo maridadi kinakuwa kitamu zaidi. Ndio maana Rock Industries Limited wanahakikisha mezani na jikoni kunapendeza kwa kukuletea vyombo maridadi vya plastiki. Vyombo hivi ni vya viwango vya juu, vyenye rangi nzuri ya kupendeza, umbo wa kuvutia na vinadumu. Baadhi ya bidhaa za plastiki kutoka Rock Industries Limited ni vikombe, glasi, sahani, jagi, begi, bakuli, vijiko, vichana na kadhalika. Na bidhaa hizi muhimu zinapatikana katika duka lililo karibu nawe pamoja na maduka ya jumla kwa bei nafuu. Kwa maelezo zaidi, wasiliana na Rock Industries Limited kupitia nambari 0722575619 au 0736028181.
Did you know at Ruiru Mabati Factory you can open an account and lipa pole pole at your convenience? Did you know at Ruiru Mabati Factory you can get customized sizes according to your roof plan to avoid wastage? Did you know Ruiru Mabati Factory offers free delivery countrywide within 72 hours?
To order, call us now on 0111 050 700. Ruiru Mabati Factory, mali safi kwa bei poa.
The larger part of the word heart is art, but the pandemic threw a disruptive brush at the galleries, the pages, and unprecedentedly drew the curtains on the stages. So, what is the future of storytelling, specifically the African story through art, media, name it? Join me, Dan Mwangi, as we discuss the rising from the ashes in the context of media and culture change at the Kusi Ideas Festival 2 in the Lakeside County of Kisumu in Kenya on the 8th and 9th of December 2020 as we march on towards a post-COVID-19 pandemic Africa and recover together.
Guess what? I will marry you.
Na hiki tumechorwa kwa mgongo yake ni map ya penye Brian amefichwa, si ndio?
Paul.
Boyo wangu, wewe ni mfani mbaya.
Sikuwe fani zaidi basi nikikutoa hizo meno zako imbo.
Wenye mdoli ni mrembo hivi na mbona kuteni mate.
Wewe, umefanya kazi?
Jabu nishamaliza kitambo. Nipe maziwa yangu sasa.
Babe. Huyu kijana si ndio yule alijaribu kunigonga na gari?
What a relief! Thank you, Gold Crown. If regular milk makes you feel uncomfortable, try Gold Crown lactose-free milk. Milk that loves you.
Every spoonful of Nutri comes loaded with the necessary vitamins, protein and minerals for you and your family to become healthier and stronger. Pick up a pack today from your nearest store. Nutri, every spoonful counts.
It is your world on this first day of December, the World AIDS Day, and we are marking it here even as we understand the status of HIV and AIDS in this country and how we are doing amidst a pandemic. Still with my panel this morning, and adherence has been said to be a key strategy to ensuring that we keep those new infections at a low, and probably will be the way we'll get to that goal of ending this epidemic. And now that we're talking about adherence, long-lasting injectable antiretrovirals for HIV treatment and prevention currently approved for use in Canada need to be administered every 1 or 2 months compared to the daily pill. Now, even as we talk about reimagining things and innovation, this is something that seems to be changing how adherence is actually achieved. Is this something we can take up as a country, Charlotte?
Yeah, well, we could, and we definitely will in time. I think sometimes what we miss out when we hear about such good progress in other countries is our context. And remember, Canada is, I mean, economically, we're talking about a different country completely. We're talking about a country that's probably able to give their population free healthcare on insurance and the rest, and we are far from there. As it is, we receive our first line and second line ART through donation, as it is, while the other countries, for their population, actually they buy for themselves, and maybe some of them are covered for insurance. So what I know about what's available in terms of long-acting ART particularly, is what's available is for patients who failed first-line and second-line therapy in the West. So they have this long-acting injectable that's administered with other drugs, but it's, you see, you failed what's available in the first place. So then it's very expensive, because as it is, our cost of first-line for Africa, because we, through the donor support, our drugs are manufactured generically, so it's substantially less than what it is in the West for first-line ART. So then you can imagine what the cost is for that particular drug, which is third line for them, and how that would be for us. We might maybe be able to pay for maybe 2-3 patients at that cost. But I do know, and I know there's a lot of lobbying globally to bring some of the cost of these drugs really substantially down, so that there's access to really that last patient who really needs it in the village, who might not be able to get to Canada, and so I'm always optimistic.
Okay.
I take, at the program, I take care of children and adolescents. So, I mean, when you take care of such people, you really have to be optimistic. You give them what's available that's best, but you are always looking forward to that new thing that's going to change their lives. If you're talking about a child who's HIV positive, for me, a long-acting treatment for them when they turn to being a teenager means they'll live longer, their adherence will be better, we'll keep them alive for longer. So really, we're optimistic that when that comes on board, then we'll have discussions with stakeholders. I mean, I really look forward to a day Kenya can be able to support its own in that and really move maybe beyond donor funding, but we'll see how we'll be able to support that in the future. Yeah.
All right. So when you talk about HIV prevention, treatment, management of the same, clearly there's a cost to it. And as we are looking into the innovations that are coming with the pandemic that we are all facing as a globe, the cost to it seems to be something that can actually give life to so many other avenues. And speaking of which, former President Donald Trump's administration had advocated for far-reaching cuts to U.S. foreign aid. And while the country now awaits what foreign policy direction the new administration will take and hope that those policies will be right on the money, international relations experts believe that Kenya has to step up its standing with the West and work towards becoming more of a partner than a recipient of aid.
Billions of dollars from the United States have trickled down to Africa in the form of aid, particularly in health-related projects, with HIV and AIDS taking the lion's share. Foreign policy and defense expert Professor Noah Midamba, however, points out that the benefits of such generosity are not as clear-cut.
You can begin giving aid for health care, as we know, And then American universities will be heavily involved in providing services in front of us instead of Africans universities involved in doing that. So the money comes in and the money goes back to America. And then whatever little we have is taken by corrupt means.
Kenya and the United States have been allies for years, but experts believe it's time that relationship evolved into one of mutual cooperation, where Kenya wasn't overly reliant on aid.
The partnership that Kenya has with the United States with regard to aid for HIV and AIDS, for example, was given strength in 2015 during the Obama administration. And many spectators are not expecting a big deviation from the policies under President Obama with Biden.
There's been Republican administration that were very committed to the development, the boost, for development to Africa than the Democratic administration. The only thing and the only trend that we have to watch is that this administration, and hopefully Kamala Harris administration that will follow it, will be much more inclined to working with us.
In its latest report, the USAID that receives most of the funding from the US federal government has committed 30.7 billion shillings towards HIV and AIDS care, 12.2 billion for emergency response, 6.3 billion for agriculture, and 5 billion for development food aid and food security. The US has also sponsored various other projects, including some 4.9 billion for government and civil society to improve the democratic space by empowering young people.
Some level of accountability will be expected from the incoming president with regard to the recipient states of aid.
The US has also given Kenya 2.6 billion in aid to cover operating expenses, 1.7 billion for basic education, which is undergoing changes as the country adopts the CBC system. It has also given 1 billion for conflict, peace and security. Leila Mohammed, NTV.
Well, clearly a lot of moving parts, even as we see the change of guard in the United States of America. And injectable ARVs are definitely another way of administering this life-saving medication. And Emily, I am wondering, even as we talk about the injectables and look at the future with them landing in Kenya and every person living with HIV getting access to the same, is this something that we can afford now that you are the recipient of this grant?
Really, we, as my colleague has already mentioned, we are not able to afford it as at now because we are recipients from the donor perspective, and therefore we are looking at the use of the dollar in terms of the value for the money. And if we can keep many of our people living with HIV on the first line, the better for us, because then we keep them at a level where we can manage their medication using this grant. And if we can also, and I know that there are strategies and there are committees looking at this, push our government to actually put in a lot of more domestic resources into HIV care, then we could be able to then move ahead of our game. But as a person, I would say that the third line injectables are expensive, and the more we can keep our populations in the first line, the better for us, because we are a donor-dependent country, and we are also having a very huge population that is poor and might not be able to afford it even if it was available in Kenya. Thank you.
Okay, so if we had an ideal situation where it is in Kenya, it is affordable to all, I wonder, Judy, would you take on the option of injecting the ARVs vis-a-vis having to take that everyday pill?
Okay, thank you, Gladys. Me as Judith, I will not, because I'm afraid what if I reacted to the drug injected? It will take long for me to recover. That's why I'll prefer the one for swallowing.
Okay.
Yes,
So,
I prefer that one instead of injecting.
So even if you were told that the same content in the pill is the same one in the injection, you'd still go for the pill?
Yes, I'll prefer that one on my side.
Okay,
yes.
interesting.
I'm used to it. I'm used because I've taken it for several years. So I'm not afraid of taking it even in 10 years to come or 30 years to come.
Na sio sindano unaogopa?
Ninaogopa shindano kila siku ya kuduma maybe 1 month or 3 months unaendea shindano kama depo. That's why I'm afraid of that one. Instead I'll just continue swallowing because even my routine daily, I know how it'll just remind me when to take my drugs.
Okay, clearly a lot of positive messaging around this will have to be done, just as we did with ARVs the first time they came into the country. Now, let's change focus a little bit. And building resilience and impact have been said to be a critical part of seeing the end of HIV/AIDS epidemic. Judy, back to you. How did you end up being a mentor and supporter of others living with HIV?
Okay, this one is a long story.
Let's keep it short.
Okay, thank you. Okay, it came a time when I was going to pick my drugs at the health facility, but I do see some people at their groups. I don't know what they are doing there at those groups. Yet they are the psychosocial support groups. One day I asked, what are those people doing under those trees? And they told me, are you willing? Can you say that you are HIV positive? If you are in a position to do that, we can welcome you in our groups. And I said, why not? I'm free because this one is my life, and the drugs has already prolonged my life. I'm free to do so. And they said, come next visit, we'll welcome you at our group. And I attended the group, the next coming visit. And there they show me 1, 2, 3 about the psychosocial support group, what are they doing in their groups, how long they have taken, and what are the activities they are carrying out in their psychosocial support groups. And I joined the psychosocial support group. That's how I find myself. One time I was appointed that you will assist your fellow clients with when they come to visit the health facility.
Okay.
And there, yes.
And as you're doing this, what joy or contentment do you get out of it?
Okay, thank you. With this one, I'm seeing that I've improved the life of my fellow colleagues, and some who are not willing to disclose, it has become easy to them to disclose their HIV status. They can share it. If they have come any other challenge, they can share. And it is my morale, it is my joy, because so many people have changed their attitude towards the medication. And it has made some to prolong their life, because when you cannot have someone, once you cannot get someone whom you are free, whom you can share with your HIV status, whom you can discuss issues pertaining in your life, it can become much more difficult for you to continue living as HIV positive. Like me, I'm free, I can share, I can do anything. Thank you.
Okay, Judy, and we applaud you and celebrate you on this first day of December, the World AIDS Day. And Dr. Ochola, why is it important to not only offer the treatment and management of HIV to those living with this virus, but also empower them?
Well, it's very important because it's not only about offering the treatment and services, ensuring that the commodities are there, but remember, HIV is a disease that someone is going to live with for the rest of their life. Yeah. But they're able to, if they're able to take it positively. So we have what we call positive health, dignity, and prevention, whereby we are able to offer these services to our patients and ensure that they're able to live with HIV in a positive manner. In that, they're also able, just as Judy has shared, being able to have peer mentors. So that is having people who are going through the same thing. They share their life's journey and they're able to see positive outcomes. So for example, you have a mother who's found to be HIV positive when pregnant, but they go through the journey. They're able to deliver a baby who is HIV negative because they're taking the medication well, and they're virally suppressed. So they're able to see that there's a positive outlook to life, despite having HIV. So this is very important. Be able to have children who grow up, take their medication well, and continue with their education, even go to university, take up being able get to employment, and being able to live constructive lives, and come back to the facilities and share their life stories and share their journeys about how they went through the challenges, they went through adolescence, went through their challenges, but still were able to come out positively. So definitely it's very important for us to be able to share, offer services outside just care and treatment, but also offer psychological support towards these people living with HIV, so that they're able to live a positive life and able to build the country, be able to have constructive lives and be able to build their families, build their communities, and ensure that they're having a productive life. So that's why it's very important to ensure not only care and treatment, but also offer psychological and social support. And this support is not only from the healthcare, providers, but this is also from the family, from the community at large, from also our leaders. That's why we also need support from our religious circles, so the churches. How do they come in and also be able to offer positive support to people living with HIV and not discriminate them? How are you able to work within the with the mosques, the religious leaders from the different sectors, being able to help with this within the school setup? How are we able to empower our teachers to be able to offer psychological and social support towards the children and adolescents within the school setup to ensure that they live a positive life? So this is within the workplace also. You find that people who are discriminated against because they have HIV within the workplace, how are we able to empower and ensure that they get support within their offices and their workplaces to be able to get their services and still also get support from their workplaces and ensure they live a productive life? So definitely it's very, very important so that we are able to have a holistic patient, not only giving them the medication, but also they are able to live a whole life even though they are HIV positive.
Elizabeth, do we replicate the same when it comes to TB, saying that HIV and TB are also highly related?
Yes, thank you very much. Because one thing with TB, if you don't take your medication, we usually, when we get a client that is TB and maybe they're HIV positive, although even if they are not HIV positive, we advise them very well to take their medication, because if they don't take their medication very well, they are more prone to get the severe forms of TB, which even take longer treatment. And you know, TB is infectious, it's airborne disease. If they don't take their medication, they need to care also for their loved ones. So this is very important for them to accept that they have TB. And the good thing that we tell them, TB is curable. So they need also to protect their loved one and also the community at large. If they don't take medication very well, it's a problem, because they'll be there coughing out and they'll be spreading the infection to other population. It will be a major problem to us. They are also going to get the severe forms of TB, which is very hard to manage. The patient that we are having with drug-resistant TB, they take medication for long, 18 months, that is almost 2 years. So for them, it's all personal responsibility. We tell them also the side effect, the drug, they have the side effect. They need also to report when they are getting this side effect of the medication, so that we can see how best we can help them. So it's a whole issue of health education and acceptance. So it's a shared responsibility with the healthcare worker. We also discuss with them the best timing for them to take the medication, because we don't want them midway the medication. The normal treatment of TB is 6 months. We don't want them after 1 month, they have defaulted, they have gone away from their medication. So we need to know what is the best way for them to give medication. We need to work with the patient, because for us to end TB, which is the goal of 2035, we need, the first pillar is patient-centered. So we put the patient at the heart of TB medication and understand their needs and explain to them. So it's about shared responsibility together with the healthcare worker. Yeah.
Thank you, Elizabeth. Now, as we bring this conversation to an end, ladies, I'd like brief comments on the same, especially even as we look at the statistics in as far as how Kenya is doing in as far as this epidemic is concerned, and how and what lessons we have learned within this pandemic that is COVID-19 that we can carry on in the future. And I'll start off with you, Emily.
Okay, thank you. One thing we've learned during this pandemic is the fact that we need to do a differentiated care, both at community and at facility level, in a situation where those who are not so vulnerable and those who are adhering are given multi-month drugs, and those who are very vulnerable are given more intensive care. We also need to ensure that we have our healthcare workers skills sharpened to be able to deal with HIV treatment within a pandemic. We also must ensure that we have our technology on notch so that we can use telemedicine quite a bit to reach to the people, and we must also ensure that we are doing community education and community sensitization, integrating all the other community components of prevention with prevention of COVID, just to ensure that people have a good understanding and are taking care of themselves as they go about their businesses. The most important for our government is also to ensure that we have a human right approach to service delivery and to health provision. Thank you.
Thank you, Emily. And for you, Dr. Chola?
For me, what we've learned really during this COVID-19 pandemic is that being able to sustain the services that are being offered even during a pandemic. Remember, we've not had a pandemic in the world for many years. So this was new for us, but being able to adapt fast with changes and things that come within, for example, the pandemic, being able to adapt, that is from the facility level, our healthcare workers being able to adapt, being able to innovate and devise new ways to ensure that our services actually reach the patients that are required. Being patient-centered, using a patient-centered approach, and being able to offer services even during this time of a pandemic that is safe and that is in a way that is acceptable to our clients, and ensure that there is continuity of services. So being able to do that, ensuring that our patients are safe, our healthcare workers are safe, and there's continuity of services. And this has enabled us to come up with innovative ways, as Emily has mentioned, that using telemedicine, being able to ensure that we're able to use our virtual platforms to ensure that services are continuing, being able to ensure that our stable patients are able to get their medication without having to come to the facility, and ensure that they are still able to continue and adhering to their medication and treatment. So we have learned a lot, and we know this will enable us to even offer better services and ensure that service delivery going forward will even be more efficient and effective, whether we have a pandemic or not. And even if another pandemic comes, it will be very easy for both the healthcare workers and the patients to adapt and move forward. So we've learned quite a bit.
Thank you, Dr. Chola. And Elizabeth, what are some of these lessons you've learned out of this pandemic in as far as the management of TB is concerned?
Thank you, Gladys. For me, I'll pick the pillar number 3 of NTB strategy, which talk of innovations. And we have had a lot of innovation since March, just to ensure that our patients receive treatment and care in a different way. Patients were not coming to the facility. So what did we innovate? Going to them in the community. We were offering a lot of community services, a lot of targeted TB screening in the communities. We even integrated TB services in the community, immunization, other services that were being offered, even giving TB services during COVID, and also having community TB management, managing our patient in the community by use of our community health volunteers. So innovation is really key, and it has really worked for us. And I believe even going forward, these are some of the strategies that we are going to employ, even if the pandemic ends. We have seen that these strategies of innovation, they have really assisted. Even online training. We came to realize when you put people in one training, the physical training, our healthcare worker from the private facilities could not have time to come for a training of 5 days. But when you have an online training, we had more healthcare worker logging in to understand the issues of TB, to understand the difference of TB and COVID. So we are getting more people wanting the trainings online. For us, this is a positive and something that we are going to maintain and manage it. Even managing our clients that are drug drug resistant virtual meeting. So innovation is the key, and we are going to manage it and move forward. We are going to use it. Thank you.
Thank you, Elizabeth. And of course, the heroine in this conversation, 13 years living positively with HIV. Judy, what would you like to encourage others who walk in your shoes?
Okay, thank you. I'll encourage the linkage for many clients on community ART and facility ART so that they can be easily access the drugs within us. Another one, I'll refer them to listen to the information from the radios and the television so that they can get the information about the COVID so that they can make themselves safer and clean. Another point, stay on course. Stay on course. I'll refer the clients so that they can get from the CHV who are within them, can give them the information so that they can know how they can put themselves clean, safe, and avoid the gathering within the burials and the funerals so that they cannot catch the COVID-19. Another point. Okay, I'll tell the clients to keep on taking their medication and continue adhering to medication so that they can be more stronger not to get any other disease like COVID-19. Thank you.
Thank you, Judy, and we celebrate you this World AIDS Day right here on your world. And of course, as we said, our national theme for the day is Comesha HIV and COVID-19, hashtag Tuwajibike. Now, with this in mind, how can Kenyans be part of this cause, Charlotte?
Thank you. So I think Kenya, it would be really good if, particularly on this World AIDS Day, we could get more Kenyans aware of their HIV status, particularly those who do not. I mean, you want to know yourself, you want to be educated on what to do. So the first step for me today, and my first call to Kenyans today, is if you've not had your HIV test this year, kindly step out today, go and have your HIV test done, and then know your status. I mean, it allows you to plan around your life, it allows you to plan so you know what's accessible to you and what's available to you. Yeah, thank you.
Okay, thank you. And that was Dr. Charlotte Paherogo, Pediatric Adolescent Technical Advisor at the National AIDS and STIs Control Program, abbreviated as NASCOP. Elizabeth Moeni in the other studio, who is a County TB Leprosy Coordinator. Joining us virtually, Dr. Cornelia Ochola, who is the HIV Technical Lead, Center for Health Solutions Kenya. Emily Muga, Head of Global Farm Program at the Kenya Red Cross, who joined us from the comfort of her home. And of course, Judy Atieno, who is a Community Antiretroviral Therapy Treatment Supporter, joining us from Siaya County. Again, ladies, I applaud you and wish you all the best, even as we continue to mark the rest of this first day of December, which is the World AIDS Day. Now, before I call it a day, I understand we still have you engaging us on that hashtag new normal. Abukuse Mike says people living with HIV who are initially accessing ART in the cities pre-COVID and have lost their jobs are currently up country and have to move between facilities accessing ART. Now, access to viral loads for treatment monitoring is a challenge for these clients. Some ART treatment sites were changed to isolation centers in some counties, and this has caused confusion on where to access treatment among the HIV positive clients. We hear you, and this has actually been addressed. Chifu Benzere says hata itaongezeka ile vituko vimefanywa hii miezi ya shutdown havijawahi onekana. Chifu, we hear you, and a lot of personal responsibility needs to be exercised in this season. Mtemi says Migori, Kisumu, Siaya, and Homa Bay, this is where your priority should be, not collecting BBI signatures. We hear you loud and clear, Mtemi. Monica says, serikali kwa wakati huu ngumu wa corona inasaidiaje waathiriwa? Well, I think the stakeholders on this conversation have touched on how each of them ensuring those living with HIV are catered for in the pandemic. Rose Munyao says, yes, I know two who are not working and have no food. Rose, that is a very sad state of affairs, and I wish you can let us know where exactly that is so that those in this discussion can see how to reach them. Stephen Otieno says, those I know have a problem in accessing medication and food give-outs from well-wishers. Stephen, we hear you. Please let us know where exactly this is. Jacqueline Kwanzaa says, yes, a very vibrant lady who has lived with it for more than 10 years, who's always ready to give us pieces of advice each and every year at our seminars pertaining the disease because our work is very delicate, thus we can be infected at any time. I salute you, my dear, for being that bold. May God continue blessing you and think this is Judy. Kudos to you. Lucy says, I have a pupil who sent me to his grandma. He said, teacher, ambia shosh nimechoka kukunywa dawa na mimi sio mgonjwa. I felt for him but also really talked to him about him being special. And this is actually being told about your status, whether you're young or whatever age you are in. Well, thank you for being part of this conversation on this first day of December. Remember, it's a World AIDS Day. Let's be our brother's keeper, but also take personal responsibility in ensuring we're part and parcel of the efforts being put together to end HIV and AIDS by 2035? All right, we are all on board on the same. Well, tomorrow we set our eyes on the adoption process in this country. Many people, especially couples unable to have their own children, opt for adoption to build or expand their family. However, many have shied away from this process, terming complex and emotional draining system. So we find out what the intricacies of adoption in Kenya are from 7 a.m. tomorrow. See you then.